Not serving turkey, but that seemed like a bad idea, so pizza it is. We're really happy to have as a speaker today Professor Sean Oz. We were having a conversation about how best to pronounce that name, so I got it relatively right. Norwegian by extraction and with some kind of accents over one of the A's that we can't remember how to pronounce. So we're really thrilled to have Sean with us today. As you probably saw in the announcement of his talk, he is an assistant professor of philosophy and a senior research scholar at Georgetown University in both the Department of Philosophy and the Kennedy Institute of Ethics. His PhD is from Brown University in philosophy, and he also is a Greenwald faculty scholar, which is taking up some of his energies at the moment. He works in areas which include the topic of today's talk, including bioethics, metaethics, and social and political philosophy. And he focuses in large part on issues of disability. He'll speak today, as the title slide says, Disability and the Public Value of Health. He plans to speak for 40 or 45 minutes, preferably without interruption, and then we'll take questions and comments after that. So thank you for being here. Please join me in welcoming Professor Oz.
So thanks so much for inviting me. I'm really excited to talk to you guys about this stuff. So I'm going to talk today about disability and the public value of health. Make sure I've got my timer. So in particular, I'm going to talk about various methods that policymakers and others use to rank outcomes of policy choices in terms of the value of health, the health states that we find in those outcomes. So policymakers need information about the value of health states to decide which to promote and which to prevent, right? Now, a really simple way to measure health would just be to use something like life expectancy, right? So do the policy which saves the most lives, extends life the most, produces the most additional years of life, right? But just on a little reflection, it seems clear that that misses a lot of stuff that we really care about in health, namely morbidity, right? Quality of life. So we wouldn't want to spend all our resources to slightly extend life, the life of one population at a very low quality of life, when we could use those same resources to improve the quality of life of another population a lot over a long period of time without necessarily extending the life of the second population. So if you want to be able to do kind of evidence-based, sort of rigorously justifiable policy making using these kinds of health rankings, you need some way to quantify morbidity, right? You need some way of saying how you can comparing adding a year to someone's life, extending their life, to improving someone else's life, right, or even improving the same person's life. And so health economists have developed various methods for quantifying the value of health. They typically involve assigning a value between 0 and 1 to a certain kind of health state, right, say deafness, and then saying that there's at least a sense in which we treat the value of 1 year of, say, deaf life as being 80% of the value of 1 year of healthy life. I present that in a kind of unflattering way for the approach because that's the kind of criticism, one kind of criticism I'll wind up making of it. But put more sympathetically, the thought is, look, if you could, if you can prevent 5 cases of deafness for a year, say, or extend one person's life for a year, right, there's got to be some number of cases of deafness such that you ought to prevent the deafness instead of saving the life, right, or extending the life. And putting the value of the value of deafness, as it's called disability weighting, the kind of subtraction that deafness makes from the quality of your life, putting that at around 0.2, which most of these rankings do, expresses something about trade-offs between the harm in having that morbidity and the harm in losing a certain amount of life. So there's a long-standing sort of disability-based critique of this whole methodology, this way of making health policy or using these rankings, these morbidity-mortality comparisons to make actual decisions about how to distribute health resources or which policies to pursue. There's a long-standing criticism that points out that, look, if you say that a year of deaf life is only worth 80% as much as a year of healthy life, then if you're in a situation where you're choosing between saving the life of a deaf person and saving the life of a healthy person, of a non-deaf person, right, you're going to have to choose to save the life of the healthy person, right? So you can imagine that you're in a pandemic and you have a limited supply of vaccines, right? You've got pandemic flu, people are dying in the streets. If you're trying to maximize the number of quality-adjusted life years that you get from your vaccine, you're going to give it to people who don't have any kind of health problem or impairment, right? Because if you save, assuming holding life expectancy equal, if you save 1,000 people's lives who don't have an impairment, you're producing, say you save 10 years of life of 1,000 people who have no impairment, you're producing 10,000 qualities or quality-adjusted life years, right? Whereas if you save 1,000 people's lives for 10 years, right? If you extend 1,000 people's lives for 10 years who are deaf, you're only producing 8,000 qualities or quality-adjusted life years, right? So this is what's sometimes called the quality trap. We think that this is, a lot of people think that this is a profoundly implausible implication of the claim that we should promote quality-adjusted life years as opposed to just indifferently promoting longer life for everyone. But it's a trap because we also don't want to say that, again, that it doesn't matter how high a quality of life we produce with our healthcare interventions or health policies, right? We don't want to say that all that matters is extending life, or we're going to wind up distributing resources in really implausible and problematic ways that ignore the relevance of health to how good your life is, in addition to how long your life is. Okay, so that's all just to kind of introduce the idea of health state rankings, disability weightings, and how they're used to construct this measure of the value of health, known as quality-adjusted life years, give a little bit of a sense of some of the traditional disability-based critiques of that approach, and then actually the remainder of the talk is not going to be about how to get out of the quality trap or about the technical details of quality-adjusted life years, but rather about some other sort of lessons that I think that we should take from recent disability scholarship and activism that provide reasons to be skeptical of the quality framework and the kinds of health state rankings that it produces. So I'm going to take two major points from recent disability scholarship and activism in philosophy and in other fields. So the first is that reasonable people can disagree about the relevance of health to welfare, right? So when I said before that a year of deaf life is worth 80% of the year of hearing life, some of you may have been offended by that, or at least imagine someone who would be, right? There are some deaf people who say, no, my quality of life is just as good as a hearing person's quality of life. And similarly for people who are blind, people who have mobility impairments, there's a good case to be made that these impairments are either not harmful at all or not as harmful as they're typically taken to be. So people disagree. Drawing on ideas from liberal political philosophy, I'll suggest that this means that since the state should respect reasonable disagreements, state policy, shouldn't be guided by rankings that make tendentious judgments about welfare. Then I'm going to make a partially separate point, again drawing on here what's sometimes called the social model of disability, that the value of a health state depends on the environment. So there's some sense in which we can't rank health states in and of themselves according to their value, right? Whether it's good or bad to be deaf, or the extent to which it's good or bad to be deaf, depends on the level of accommodation. And I'm going to say this is something that policymakers cannot forget, and there's a danger that the usage of health state rankings of the kind that the quality framework produces will lead us to ignore or downplay the importance of the environment to determining the value of health. Okay, so the first set of points, disability and welfare. Okay, so when we say that a condition like deafness is 80% or 20% worse than has 20% disability weighting is 20% worse than full health, what do we mean? Well, some people actually intentionally interpret it as, and I think many people might be tempted to interpret this as just making a claim about health, not a claim about welfare at all, but a claim about how healthy people are, right? So the claim would be that a deaf person, everything else being equal, is 20% less healthy than a hearing person. Or that a person, to take a different weighting, a blind person is 40% less healthy. Or someone who's had their leg amputated is if you were to look back at the figures, it's something about anywhere between 25 and 65% less healthy, depending on the particular weighting scheme you're looking at. But I think, and I think Dan Hausman has argued persuasively that we shouldn't understand disability weightings in terms of just a kind of degree of health, a comparison in the overall health of one person as compared to another person. Because I think there actually, and Hausman, to my mind, argues persuasively, that there isn't a lot of sense to be made of quantifying the health of a whole person as compared to another person, right? Of saying that one person is 80% as healthy as another person. You might be able to say of a specific organism or part that it's functioning at a certain percentage efficiency as compared to someone else's function or part, right? So you might be able to say, knowing what the function of a particular thing is, like a kidney, you might be able to say one kidney is functioning 80% as well as another kidney, right? But what's the function of a human body, right? How do you compare quantitatively how well one whole body is functioning with another whole body? So I'm happy to talk about this in Q&A, but I take Hausman to have shown that there's no conceptual sense to be made of that comparison. And if there is, it's one that wouldn't matter normatively, right? You might say the point of an organism is to survive and reproduce, right? But we don't think that the point of medicine is only to help people survive and reproduce, right? In fact, that's part of the whole point of bringing in morbidity, is that it's not just survival that matters. And of course, lots of kinds of morbidity matter besides fertility-related morbidity. So this is to say that what these health rankings are measuring when they say things like the disability weighting of amputation is of missing a leg below the knee is 0.3, they really are saying that it's 30% worse to be missing that leg than to have that leg, right? It's 20% worse to be deaf than to be hearing. It's a claim about welfare or quality of life. And that's implicit in the name. They're called quality-adjusted leg figures. Okay, so I think that recent disability scholarship and activism poses profound challenges to this claim in at least many cases, right? So for instance, to the claim that it really is worse, 20% worse, to be deaf than to be hearing, right? So, or 30 or 40% worse to be paraplegic than not, right? So many of you may be familiar with the Brickman et al. Study from 1978. This study found that if you look at people a couple of months after certain apparently profoundly positive or profoundly negative life events, you'll find that they report roughly the same level of satisfaction, whether it was a positive event or a negative event, and whether, and as compared to the life satisfaction of people who haven't experienced major life events report, right? So paraplegics report similar life satisfaction to recent lottery winners if you go 6, 7, 8 months out from the time of the change, right? Generally, disability and quality of life, self-reported quality of life is a much studied area. There's no consensus view about the extent to which disabled people are in general worse off or have lower welfare than non-disabled people. But many disability scholars argue that, say, after an injury, most people do tend to recover full quality of life if it's not a sort of super major impairment. If you're still left with a lot of functionality, you get used to it, and then you're just as happy as you were before. Someone who's born with an impairment doesn't miss the capacities they don't have, and so tend to report similar levels of life satisfaction to people who don't have impairments. So this is to say that it's at least not obvious from what quantitative evidence we have that people who have impairments think that they're worse off than people who don't, right? We also have qualitative evidence of this. So here's a quotation from Harriet McBride Johnson, a disability activist. She says, "Are we, that is disabled people, worse off? I don't think so. Not in any meaningful sense. There are too many variables. For those of us with congenital conditions, disability shapes all we are. Those disabled later in life adapt. We take constraints that no one would choose and build rich and satisfying lives within them. We enjoy pleasures other people enjoy, and pleasures peculiarly our own. We have something the world needs," right? So there's a recent growing trend among people who think about disability, right? Disability scholars, activists, philosophers of disability, to assert what Elizabeth Barnes calls the mere difference view of disability in general or of specific disabilities. So this is the view that being disabled is not worse than being non-disabled, at least in many cases, right? It could be contraposed with the traditional bad difference view of disability, which says that normally it is worse to be disabled or to have specific disabilities like deafness than not to have those disabilities. So I'm not going to take a stand on this debate here. I just want to point out that there's a lot to be said for the mere difference view, right? There are powerful arguments that have been made on its behalf, both based on quantitative evidence and based on the testimony of disabled people. So again, I'm not asserting it, I'm just saying, look, it's a reasonable view. On the other hand, I think the traditional view is also reasonable, right? The traditional view that it's at least somewhat worse to lack certain normal human capacities than to have those capacities. I think that's also a view that a thoughtful person could come to, right? I think that these are both reasonable views. Existing ways of coming up with disability weightings, right? The methods that they use to come up with statements like deafness is 80% as good as, a year of deaf life is 80% as good as a year of hearing life. In the best case, these come from broad-based surveys of populations. We use various methods to try and elicit people's actual judgments about the value of these health states. And then you average those, right? So that copes with this disagreement in a kind of distinctive and I think to me problematic way, right? So you're going to get some people who hold the mere difference view in the population and some people who hold the bad difference view, and then you're just going to split the difference. You're just going to take the average, right? And so to me, and I think certainly to many proponents of the mere difference view, this is going to be no compromise at all, right? In a sense, right? If I think that you and I disagree. You think that it's quite bad to be deaf, and I think it's not bad at all, right? Settling on it's sort of bad isn't going to strike me as a reasonable compromise, right? And to you, it might seem like an unmotivated compromise too, right? You might be moved a little bit, like, okay, I kind of see it's not quite as bad as I thought, but you might think, no, I have some theory of the good, or I have some firm conception of what it takes to live a good life. Like, I think you need to be able to listen to classical music or whatever to live a good life, right? I'm really convinced of that. Let's imagine. The fact that some other people disagree isn't going to move me to change that view. In any case, this way of dealing with reasonable disagreements is not normally how we approach these issues, where we have these kind of profound disagreements about what's good in life, and we have to make policy which seems to touch on the relevant issues, right? So, imagine another area where we have reasonable disagreements. Classic case that liberal political philosophers consider is disagreement about what religion is the correct religion, right? So, when we have half the population is Catholic and half is Protestants, not really the case, but just imagine, half the population is Catholic and half is Protestants, we don't compromise between Catholicism and Protestantism by all coming to accept some syncretic religion which accepts elements of each and making that the established religion of the state, right? No, what we do is avoid the whole issue. We don't have an established religion of the state, right? So this is the idea behind what political philosophers have come to call public reason liberalism. This is the idea that where we disagree reasonably and profoundly about conceptions of the good, conceptions of what makes a life good or worth living, then we should make policy in a way which doesn't contradict any reasonable view about that question, right? At least insofar as that's possible. So I think the way that this is sometimes understood in the political philosophy literature, the idea of reasonable disagreement about the good, it's understood as disagreement about things like salvation, about the kind of lofty things of the good, like what makes a life perfect or ideal. But I think that what some of this disability scholarship shows is that there's a lot of disagreement about more prosaic elements of our conceptions of the good, right? Not just about what's going to happen after you die, right? What's the ultimate meaning or purpose of life, but also what makes a life good or bad in the here and now, right? So, some of us who are seeing and hearing think that part of what you need to be able to do to live a really good life is to experience certain kinds of sensory pleasures or experiences. Whereas some deaf and blind people tell us that that's not the case, right? And so we disagree about what you need to do day to day to be happy and live a good life. And I think given that we disagree about that and that disagreement is reasonable, right, that it's a disagreement that can persist among thoughtful, well-meaning people, in making policy we should, as far as possible, try to avoid controversial judgments, not just about salvation, not just about the lofty parts of good, but also about well-being and welfare, right? So I think that this is a powerful point of convergence between recent disability scholarship and activism and the tradition, the kind of liberal tradition in political philosophy. Okay, so turning to the second set of points. So public reason liberals, I think all of us should be public reason liberals. We shouldn't just say, no, my conception of the good is the right one, and I'm going to impose that on you whether you like it or not, right? My conception of welfare is the right one, and I'm going to impose it on you whether you like it or not. Or the average conception of welfare, which is nobody's conception of welfare, is the right one, so I'm going to impose that on you whether you like it or not, right? I think we should all be public reason liberals and avoid those kinds of impositions. But look, we still need to make health policy. We still need some way of valuing health students, right? We still need to say, you know, when we should send the vaccine here and when we should send it there, right? When we should develop a cure for this condition and when we should spend our money preventing the development of that condition instead, right? We need some way of knowing, like, what we should be trying to accomplish in health policy. So we need some way of ranking health students. So philosophers who, as it happens, are public reason liberals, although who have not always described the motivation for this view in terms of public reason liberalism, suggest a way of thinking about the value of health which isn't dependent on judgments about well-being or welfare, right? So philosophers like Norman Daniels, working in the broadly Rawlsian tradition, have suggested that what we can all agree on is that it's important for people to be able to engage in certain kinds of public activities, right? It's important for people to be able to take care of themselves to the extent possible, to hold jobs, to have some kind of social life. There are certain resources that you need to do those things, to have those capacities or capabilities, right? Certain versions of the capabilities approach can agree with this, to pursue these opportunities. And the thought is that the state's business in health is to improve people's ability to do these kinds of things, right? The kinds of normal activities that constitutes a life in society. So Daniels, in developing this idea, does not propose any way of quantifying the value of health in terms of its impact on opportunity. But Daniel Hausman, in his recent book, Valuing Health, has done so. So Hausman's idea is that there are two things that matter about health from the perspective of a liberal state, right? There's this opportunity thing that Norman Daniels is talking about, the impact of our health state on our ability to do things, and there's also just this kind of pure element of distress or suffering, right? So a compassionate state should care about people suffering, not as part of some general conception of what makes a life go well, but just roughly because we can all agree that it's bad if people are in pain, whatever else we think about the value of different things for people's well-being. So Hausman thinks that what we need to rank are these kinds of pairs of limitation distress pairs that constitute the boxes in this chart here. So how does he arrive at these rankings? Okay, so the first idea is to differentiate different levels of limitation and distress, right? So we know how many boxes we're going to have to fill in. And Hausman says, well, you know, we're going to need to have some manageable set of levels to differentiate if, you know, this is going to be a kind of workable framework. And so he proposes 6. He's sort of basing this on previous research on health-related quality of life, including something called the HALEX study, but he's modified that somewhat in thinking about different limitation levels. So limitation levels range from no limitation at all to what he calls minor social or occupational limits. That's like not being able to do some jobs or not being able to do them in the same way that other people do them. Major social or occupational limits is not being able to do kind of a lot of jobs. Physically limited in instrumental activities of daily life, that's what IADL stands for. That's like not being able to go shopping, not being able to do things sort of outside the home. Below that is limited physically in activities of daily living, simpliciter. So those are things that you do in the home, like cooking or using the bathroom. If you're at this level, you need some kind of home care. And then he thinks it's actually worse to be cognitively limited in these basic activities of daily living than physically limited. I'm not sure why he thinks that, or if I'm persuaded. I'm not going to focus on that aspect of this framework going forward, so don't worry about that. And then he just differentiates distress, at least for illustrative purposes, into just 4 levels: none, mild, moderate, severe. There are going to be hard questions about how you measure distress as he's understanding it and what counts as distress. Again, that will not be my main focus. So as it turns out, he thinks in terms of the effect of suffering on the value of a person's life from a public perspective, right, on the extent to which we should try and prevent a given bad health state. He doesn't think it matters how much you're occupationally limited in thinking about how much your distress matters. This is potentially controversial. Some people would think that if you're worse off in one dimension, then your well-being in the other, or your well-being in the other dimension matters more. But again, that's not a point I'm going to press. That's the kind of thing that what philosophers call prioritarian might say. As it happens, the way that the chart is actually constructed is the number in each column is just fixed decrement from the previous column in each row, so it doesn't have that formal feature. Next step is two steps. The next step is to evaluate public imports of the limitations using surveys and information about labor markets, right? So somehow he's constructing this information about how much worse it is from a public perspective to have minor social or occupational limits as compared to major social or occupational limits, right? The idea being that it's about 25% worse. He gets that, and these numbers are, to be fair to him, meant to be very preliminary, but he gets that by trying to get some kind of back-of-the-envelope data about how much people in these different limitation levels, how much money they make, what their average income levels are. The thought being that that gives some kind of approximation of how other people in society value these kinds of activities, right? If you're willing to pay people X amount to do a certain kind of activity and Y amounts if they can't do that activity, that gives you some fix on the relative valuation of those two kinds of activities. So I'm not sure about that either. I'm happy to talk about that in Q&A. My main concern is the final step, which is where you take this ranking of limitation distress pairs, right? You say, look, if you're physically limited, if without this intervention someone would be physically limited in instrumental activities of daily life and have moderate suffering, then we should give that much weight to 0.5 weight to the year that would be produced by that, and if we could avoid producing that harm, that decrement from 1 to 0.5, then that gives us that much reason to do so. So you have this ranking of these different limitation and distress levels, but in order to know how to use that for health policy, you have to know how that corresponds, at least lots of kinds of health policy, you have to know how that corresponds to specific conditions, right? So the health-related quality of life measures that I started with were weightings for specific conditions like, or syndromes like total hearing loss or the loss of a leg, right? You need to know that because you need to make choices like how much should we invest in preventing accidents which lead people to lose their legs, right? Or how much should we invest in fancy cochlear implants that improve people's hearing loss? And so there's got to be some way to map specific medical conditions to these boxes. So leaving aside the distress issue for now and focusing only on health states which don't cause any intrinsic distress, right? Any distress they cause is maybe a result of the limitations they produce. We can ask, where do we put specific conditions on this chart? And there are going to be a lot of questions here, and Houseman would admit that this is a big project to actually fill this in and use it. But I think that some of the questions point to a kind of conceptual problem that isn't just a matter of details, but is really a fundamental issue with this approach, and in fact any approach to ranking health states. So let's talk about total hearing loss, right? So how bad is it to be deaf? Well, it depends, right? It depends on what your world is like, what world you live in, right? What kind of accommodations are available. It's much less bad to be deaf if you live in a highly accommodating society, highly accessible society, where you've got the things on the stoplights that tell you when it's turned green so you can cross the streets, where if there's a deaf person in the audience here, there's a sign language interpreter interpreting I talk to them. There are a variety of mechanisms we can implement as a society which affect the value of these health states, right? And so, sort of sub-specie aeternitatis, right? From the kind of view from nowhere, there just isn't a way of assigning a health state to a limitation level, right? It depends on what else is going on, right? And so, a wise man once said, because health states have different evaluatively relative consequences in different contexts, token health states will have different values, and health states of a given kind will have no uniform values at all. Since the value of a kind or type of health state is not defined, it cannot be measured. There is no such thing as the value of a kind of health state. So there is no way to measure the burden of disease by measuring the value of the distribution of the kinds of health states it causes, right? I haven't used the language of measuring the burden of disease, but that's part of what we do with these quality rankings as or Hausman's public value rankings, is we're trying to determine how much of a burden a certain condition places on the population so that we can figure out the priority of methods that would address, treat, cure, or prevent that condition. So I think that this quotation points to a very general argument that we can make about health state rankings. So here's the argument. This is kind of definitely wearing my philosopher hat here, but I think this is helpful. So the argument goes like this. The first premise is that the health state of an organism doesn't depend on facts about its actual environments, right? So I'm using depend in kind of a philosopher's way here. It doesn't depend constitutively or directly, right? Like whether I'm going to be healthy, of course, depends on like whether there's pollution in the air and things like that, right? But the pollution doesn't make me unhealthy without getting in and doing something to my body, right? My health state doesn't change until something under my skin changes, right? Until there's some kind of change in the configuration of the parts of my body, right? A philosopher might say, I think I'd be willing to defend the claim that health states supervene on internal bodily states. There can be no change in a health state without some change in the internal state of the person's body, right? But look, we've just seen, and certainly the long literature on the social model of disability amply demonstrates that the value of the health state of an organism does depend on facts about its actual environment, right? Whether and to what extent it's good or bad to be deaf depends on the level of accommodation. And that's going to be true of a ton of other health states. Maybe not every single health state, but it's going to be true of a lot of health states, a lot of things that we would think of as pathological conditions, that how good or bad it is to be in them is going to depend on all kinds of features about the environment, right? But it just follows from this that health states themselves can't be evaluatively ranked, right? You can't rank the value of health states, it's impossible. Any rankings are necessarily environment relative. So this way of kind of regimenting and specifying this argument is my own, and if you have objections to it, I'm happy to talk about it and refine it. The argument itself was originally made by John Broome and also by Dan Hausman, as it happens. So the quotation I read is actually a quotation from Dan Hausman. And so part of my point is that I'm not sure that the positive health rankings that he's produced take this point into account sufficiently, right? At the very least, any approach to ranking health is going to have to make it explicit what environments you're relativizing to, right? So what's the environment you're thinking of when you say that deafness has a value of 0.8, right? So we're typically, in the way these rankings are constructed, some of the people who construct these rankings are philosophically sophisticated. They've read Broome, they've read Hausman, and they say, well, we are ranking relative to an environment, right, saying quality rankings. It's just the kind of average environment worldwide, right? So in some places accommodation is poor, in some places accommodation is good, and since we're taking surveys of people all over the world to come up with these rankings, what we're getting is in effect the average, right? Another approach says, no, we should go with more like the highest extant level, the highest existing level of accommodation, and otherwise we're maybe discriminating against certain people. It's a complicated conversation which of those we should use. My point is just that either way you go, you're relativizing your ranking to the actual environment, right? You're asking how well people with this health state will do in the environment as it is right now, right? And that's not an unsensible thing to do, right? If you're the WHO and what you can do is health intervention, right? The levers you can pull are levers that ultimately will affect how people's bodies work, then it makes sense to focus on, look, what will happen to people's health states in the actual environment, or the value of their health states in the actual environment, if we do this policy as opposed to that policy, if we push for the development of this treatment as opposed to that treatment. And for a lot of health policymakers and health actors, that's going to be a relevant question. But if you're the state, or if you represent the state, then you have to ask another question. You have to ask not just how what is the environment in which we're making the health intervention, but you also have to ask, what should we do to the environment? How should we transform the environment, right? Should we maybe, instead of spending the money on curing people's deafness via expensive cochlear implants, instead pay for more sign language interpreters, right? You have to have that question in view if you're going to fulfill your responsibility as an agent that has some degree of control both over how people's bodies are and over how the environment accommodates those bodies. So I think what we would ideally use, the kinds of rankings we would ideally use for health policy when we're in a position to affect both the environment and the body, would be rankings of sort of health state environment pairs, right? So we would want to know how good or bad it is to have moderate or total hearing loss under different levels of accommodation, right? In different kinds of environments. So the thought is we need to introduce this information to make decisions that we need to make if we're the kind of agent that can choose between healthcare and accommodation in policymaking. So since we're that kind of agent, we have to use a different kind of ranking, at least sometimes have to use a different kind of ranking than the kind of ranking that is actually used, and then the kind of ranking that Hausman proposes to use. So why so? Well, I have some crude charts, which hopefully will help to make this point. I apologize for the crudeness of the charts. In philosophy grad school, they don't teach you how to make PowerPoints, much charts. So I'm catching up. But so these are made up numbers for the value of these health states, just like Hausman's, although I've made them up instead of Hausman has made up. But this chart represents the kind of information that I'm saying that policymakers need. And I want to illustrate why having this information would allow us to make judgments, decisions that are better than the judgments or decisions we can make without this kind of information, right? Again, this is information about how good or bad a health state is. I'm going to say, pursuant to the first part of the talk, in terms of something like opportunity or limitation, right? How good or bad a health state is in different kinds of environments. So the value of the health state increases as you go up the charts. The level of accommodation increases as you go from left to right. So I'll start by comparing the sort of curves that we could get for two different kinds of related conditions, right? So total hearing loss is the blue line, and moderate hearing loss is the orange line. Assume for the sake of argument that we're talking about causes that don't produce any non-limitation related distress, so we're not talking about the kind that comes with tinnitus, which we might think of as involving a kind of suffering. That's going to introduce additional complications which will need to be reintroduced into the model eventually. But just talking about the effect on opportunity or limitation, we might stipulate for the sake of arguments that it's about 20% tougher to live with total hearing loss in terms of your opportunities in society than with no hearing loss, and about 10% tougher to live with moderate hearing loss. So the information on the far left of this kind of graph is going to be the kind of information, the only kind of information that anybody has been trying to get thus far, right? That's the kind of information that's in quality rankings. That's the kind of information that Hausman is trying to get in a different, less welfarist way. My point again is that you need the information to the right to make important decisions. So one kind of decision you might want to make is between, as I mentioned before, spending money on improving people's health states or spending money on changing the environment, right? So suppose that you've got a given pot of money, and you can either move a certain number of people up, let's just say for the sake of argument, you're deciding whether to develop some kind of incredibly expensive cochlear implant, or brain-machine interface, some fancy cochlear implant, which could take all of the deaf people in the world who wanted it and give them some significant amount of hearing, although not total hearing, right? That's going to cost you a lot of money, right? And you're going to get a certain increment and improvement from that. On the stipulated values I've given, it's going to be 0.1 per person per year, right? That's going to be the magnitude of the improvement, the proportional magnitude. But it might be, right, that taking that same amount of money, you can change the level of accommodation in society such that you improve the public value of each individual deaf person's life, right? You improve their life in the relevant opportunity involving ways by a greater magnitude, right? Say by 0.12, right? So here you're just getting more bang for your buck, right? And you couldn't, and again, it's on relatively the left side of the chart because the thought is it's with the very same money, right? So this is an achievable change in accommodation. And you're getting more bang for your buck, both because you're doing more for, in this stipulated situation, you're doing more for people with total hearing loss, right? 20% more for people with total hearing loss, but also, at least sometimes, a rising tide lifts some other boats, right? So the same stuff you do to accommodate people with total hearing loss is also going to help people with moderate hearing loss, right? And so not only do you get the additional benefit to the population with total hearing loss, right, which is going to stay a population with total hearing loss in this scenario. You're not spending the money on the implant, right? You're spending the money on, a massive accommodation project, right? A lot of money to develop the implant. You do a lot of accommodation with that money, right? If it turns out that the amount of accommodation you could do with that money would produce more value for people, however we're specifying value, produce more value for people in that health state, then that's a slam dunk. That's a no-brainer. That's something you should do. So again, this is all stipulated. I have no idea whether that's the case in that comparison. But my point is that you need this information. You need to know what the value of health would be in that non-actual situation in order to know whether you could have a slam dunk, right? And so policymakers need this kind of information to responsibly make policy, is my claim. And it's not the kind of information that any current health ranking scheme provides. This is more controversial, but I think that there's another kind of information that policymakers should look at when they're thinking about prioritizing different kinds of interventions, policy interventions for people with disabilities. So this is a little more idealistic. So I think, and have argued, that there's a level of accommodation that we're sort of required by justice to provide for disabled people. And we're falling far short of it, right? We live in an ableist society. You might agree with that, you might not. But if you agree with that, judgment of mine that we live in a profoundly ableist society, or even just a somewhat ableist society, you might think that this means that there are certain people who, because of the combination of their health state and the environment, are doing a lot worse than we have an obligation to make them do, right? We're failing those people significantly, right? Those are people for whom the curve is relatively steep, right? There's a big difference between the value that their health state would have in a just society and the value their health state has in an unjust society, right? Now, there are other people who might have a similar actual level of health-related problems, right? Say some people with migraine headaches or something like that, right? Who, might be helped a little bit by further accommodation, but not a whole ton, right? So the slope of their curve on this graph is much shallower. You might think, and David Wasserman and I have argued this in a paper in the Journal of Moral Philosophy, that there's reason to prioritize people who are at the same level of disadvantage if we, the state, we, the people, we, the society, are responsible for their disadvantage, right? If your house just burns down, I might give you some charity. If I burn down your house, I better, do more than just give you some charity, right? So the thought is to know whose house we burn down, right? To know who we owe these especially weighty duties of rectification to, we have to know something about about not just how they would do under the policies we can do immediately, but how they would do if we did everything that we should do, right? So we need information not just about the relatively near precincts of the kind of space of possible environments, but also about more distant precincts. to decide which health claims or other claims to prioritize. So again, that's just to say, not as yet, not sort of for the record, to make assertions about what specific things we should do as a society, which specific valuations we should give to certain health states, which specific policies we should pursue, but just to say something about what kind of information we need about the value of a health state before we can figure out responsibly which things to pursue, right? At least to figure that out responsibly in every single case. So my conclusion, putting both parts of the talk together, is that ideally, health policy would be made using non-welfarist rankings of the value of health states in different environments, right? These kinds of terms. I mean, this ideal is far from achievable. I really don't, I know I'm probably talking to some people who study or do health policy. I really don't want to tell anyone how to do their job in any specific way, because I know there are lots of different constraints that we operate under and the kind of information we can get, and also, in many cases, we're not in control of the environments, right? This is more of a sort of abstract conceptual point about how the whole system of state policy as related to the value of health should be understood and evaluated. But even when we're, as particular policymakers or actors, not in a position to get this kind of information, I do think it's important not to forget that the kind of central core point of the social model of disability, which is that in many cases, when somebody is badly off as a result of their disability, not only is it not their fault, right, their personal responsibility, it's not a result of some choice they made, it's also not the fault of kind of the way they fundamentally are, right? It's not the fault of something that's really about them, right? It's attributable to the society. Instead, I think keeping that in mind, and I think people have argued persuasively that keeping that, the kinds of conceptual points I've made here in mind, can help us talk about disability and health policy in a way that is less sort of harmful and stigmatizing to disabled people. So, thank you.
Thank you, Sean. Let me get your microphone half second. So thanks for that really interesting talk. Pete has a microphone. Raise your hand. Oh, there's two microphones. Looks like Angie has it first, and then wait for the mic so that we can all hear you. Angie.
Hey, a great talk, really interesting. Can you say more about sort of how you determine what justice requires in terms of environmental accommodation?
Yeah, so I mean, the short answer is no, I can't say more about it. It's a really hard question, right? Or there's nothing I can say briefly about it. And for the purposes of the talk, the kind of necessary claim about that is it just requires a lot more than what we're doing. I think the project of constructing a theory of justice, which tells us what level of accommodation is required, not just which tells us tells us that is an important project. I've chipped away at it in various places, so I do think that this idea that society is responsible for some people's health states as opposed to not as responsible for other people's health states is going to be a big part of that, right? I think part of treating everybody equally is, not disadvantaging people by excluding them from valuable social activities unless there's a really good reason to do so. And if there's a good reason to do so, right, if it's too expensive to accommodate, I do think that justice requires us to provide people with some kind of compensation, right? It's like sometimes, yeah, you do have to leave somebody out, but you shouldn't treat them as if that's their fault, right? You should take responsibility for the fact that you're profiting from leaving them out and, do something ameliorative in response. And so, there are kind of a few points I can make around the edges about what kinds of information or, moral considerations a theory like that would have to take into account, but, I don't have one to give you.
All right.
So Sean, it's very nice talk, and I really appreciate the direction that you're taking here. I have one question. If you could please go back to the chart showing the vectors, whether it's point 1 and point 1, 2, 1, thank you. So how do you account here for the value of being able to travel across environments, right? So if you were to, as a better policy, make the choice that raises the level of accommodation in a particular environment, then the people who are still suffering from, or still have total hearing loss in that environment have missed out on the opportunity to be equipped to travel to other environments.
Yeah. Yeah, that's interesting, right? So we don't have a single global policymaker that is, deciding what the level of accommodation is going to be worldwide or even nationwide. I mean, in actual fact, there's a, patchwork of policymaking on all these different issues. Yeah, I mean, I would think that there would be some public disvalue to being unable to travel, but I'm wondering if that would, I'm thinking about whether that would be a reason not to do it, right?
I don't know, it might be a reason to involve the people in deliberation about it, because maybe different individuals would choose different things. I would choose to go ahead and have the cochlear implant so that I could be free to travel anywhere I want and have moderate.
Right, I see, yeah, right.
Hearing loss.
Right, so now I'm getting your point a little bit better. It's a point about the comparison that some of the value in the health intervention, the very fact that it's environment insensitive might in some cases be a good thing, right? Yeah, and I think your suggestion, your procedural suggestion that you have to involve people who have the conditions in constructing these values is absolutely essential. It can be absolutely essential to this approach. I think look, this is hard information to get. It's hard information to get about how good or bad something would be in a counterfactual situation, right? It's not something that you can easily go out and study in the same way that you can study the values maybe on the far left-hand side of the chart. But certainly the people who would have information that would be relevant to making some kind of responsible judgment would be people who have lived with the condition and know what it's like and what might be gained or lost with different options.
So I think this is just a question of clarification. On the first slide that mentioned Houseman with this picture on it, I think, I was a little confused by the conclusion. Yeah, so what does it mean that so you had a skepticism about the healthier Dan relation?
Yeah.
And I was just wondering what the nature of that skepticism was exactly.
Yeah.
It seems to make sense to say that, this person is healthier than a person who is, similar, but who has a very serious and life-threatening illness.
Yeah. Right, so it's not necessarily based in skepticism. The idea isn't that you can't ever compare someone's total health state to someone else's, right? But to get a numerical comparison, to go from, point 1 to point 2 to point 3, that healthier than relation has to have certain formal properties, right? It has to be a total ordering, right? It's got to be for any two people. You can say which one is, either one is healthier than the other, or they're equally healthy, right? It's going to have to have features like that. And the skepticism is about not any total body health comparison, but that relation of total body healthiness, healthier thanness, has the right formal features to construct a numerical ranking.
Okay.
That's it.
So, Sean, can you go back to the slide that Mariah was asking you about? I've been trying to, as you were talking, think of the concrete accommodation example that would both help the person with total hearing loss achieve that jump, that would also, as you were suggesting, help those with moderate hearing loss. So that what's the concrete example for the first category is something like a sign language translator. But a sign language translator doesn't really help those with moderate hearing loss. Presumably most people with moderate hearing loss don't know sign language, right? They can hear, but they need some different kind of accommodation. So is the argument that we should only look for accommodations that can kind of give us the greatest bang for the buck and help accommodate both those with the total and the moderate, or the most severe and the less severe? Or it kind of gets a bit to the point that Mariah was trying to raise. And maybe hearing loss is not quite the right example to figure out what the concrete
Yeah.
accommodation might be.
Right, so we might have different measures. You could imagine instead of having, maybe 10 or 15 years as speech recognition technology gets better, instead of having a sign language interpreter standing there, you could have subtitles, right? You could have live subtitling like YouTube. I mean, YouTube does a terrible job of it, but presumably in 10 or 15 years that will be more possible, right? And it might be that that's not quite as good for a deaf person because, sign language is their native tongue, right? And so the sign language interpreter is both providing a disability accommodation and a translation, right? So that's in some ways maybe more valuable. But with the kind of information I'm saying you need to get, you could compare those, right? Because you could then say, take the more universal accommodation, ask how much that benefits both groups, and compare that to the different environment constituted by the less universal accommodation, right? And ask about the total benefit in that situation. Sometimes these things are actually going to compete, right? So, I made it easy for myself by imagining situations where, I made the chart easy to draw by imagining situations or imagining conditions where I thought there isn't going to be, it's not like the things that you do for people with total hearing loss is going to make things harder for people with moderate hearing loss, right? But in some cases, you're not going to be able to use a single neat chart like this because measures that accommodate one kind of disability actually make it harder for people with another kind of disability, right? So sometimes people say this about curb cuts, that they very clearly benefit people who use wheelchairs. But at least to some extent, they may make it more difficult for people who use canes to navigate the physical environment because it's a little less clear where the sidewalk is. Now, probably that's not a real tough practical case because the benefit to people who use wheelchairs is huge and the detriment to people who use canes, my impression is that it's relatively small. But yeah, the information about the environments is not ultimately going to be kind of unidirectional, right? Like there's one environment is more accommodating of all disabled people than another environment, and we're ranking environments from zero accommodation to to perfect accommodation, where all disabled people are equally well accommodated at each level, right? It's going to need to be these charts would need to be kind of specific to particular policy contexts where you're asking about the trade-offs for different conditions, given a particular dimension or kind of accommodation.
Great. I think given the hour, we should probably finish. Say thanks to John very much for that really interesting The next seminar is December 11th. It's in Feinstone, so over in the school